clinics, and if they come up and need a patient to be seen quickly, then we can get one of our general pediatric physicians to come in and see them. Most everything is scheduled. We have 2 different scheduling systems depending on what the specialty is. Some of the physicians, we have enough patients need built up that we have block schedules with them. So as an example, dermatology, we've got every Thursday afternoon between 1 and 3. And so however many patients we can get in that 2-hour block schedule, we get them seen. Psychiatry is another thing. We have blocks of time with our psychiatrists that we can schedule patients with. Some of the others that we don't have a need for on a regular basis, like pulmonology, we schedule that into a clinic rotation, just like they would a normal patient. They just happen to be going to be seen over telemedicine as opposed to a face-to-face.
Interesting. Okay, so then you do this, and then you have a whole in-house growing system,
Yes.
for doing all the scheduling and managing of all
Yes,
the positions.
I have 2 clinic coordinators. One of them really focuses on the correctional program, and one of them focuses on the community program. We're the central office, so we work with the communities and the physicians. All of the scheduling gets done out of our office. We're kind of the middleman. We've determined that that's the best way to make this work in West Texas. They have one central contact person to, whether it's the community side or the physician side, to work with, so they're not having to work with each individual specialty on the community side. So it's made it a little more efficient for us to be able to offer those services. And it also allows us to be able to see what's going on with the clinics. I have the coordinator set in on the clinics to make sure that we're providing the quality service that we need. The connectivity is where it needs to be. The patient, they're there if the provider or the presenter on the patient side is having issues with equipment. They can troubleshoot that. They can direct them on how to run equipment. So that's kind of how we at Texas Tech are running the program.
Very cool. Good. Okay, now let's switch over a little bit into some of the key decisions you had to make as you grew your program. What can you talk about some of those? What were some of the biggest decisions that you had to make?
Well, one of the biggest decisions that we had to make was we were working on a grant project where we were originally supposed to build out 30 community sites for Medicaid enrolled children. After it was going to be a 3-year process, after the first year, the funding that was for the grant started getting cut. So we got knocked down to only doing 19 sites at that time. In a matter of 13 months, we'd built up 19 community sites for the project. And then as we moved forward, it just got to be financially, the funding source just kept shriveling up. They kept wanting more and more documentation. The focus from their level changed from what we'd originally agreed to. So basically we ended up agreeing to split and go our separate ways. And so that was a really tough decision because, the concept of what we were trying to do was so important to be able to figure out how to get communities access to care. And so making the decision to sever ties with the grantor because of circumstances, that was a tough decision because, I had grand expectations about what we were going to be able to do, and we weren't going to be able to do that in the long run. So that was a tough decision to make.
And just to ask you, so then did you have to actually stop providing services to those?
At that point in time, we gave the communities that through the grant, we were paying for several things. We were paying for the equipment, we were paying for the connectivity cost, and we were also providing salary support to people in those communities to do telemedicine. And so when the funding stopped, obviously that financial support stopped, and the clinics had to figure out how to take over and pay for those services themselves a lot sooner than we had originally planned on to begin with. You know, we were looking at how we could eventually phase the money out so that they could figure out how to be sustainable. As I mentioned, we had done 19 sites. Unfortunately, only 9 of them decided to continue on because we did not have enough time to figure out how to do that sustainability plan for them. But, you know, we learned a lot of lessons from that. You know, the focus at the time through the grant source had been for Medicaid children. We learned that you can't just focus on one payer group and try to make something sustainable. In West Texas, you know, as far as that goes, you may not have 10 pulmonology patients that need to be seen that are Medicaid patients throughout our whole 108 service territory. And so it's hard to say, you know, they were trying to make us, you know, sustainable for each one of the different specialties, and there just wasn't enough patient base for Medicaid patients to be able to do that. And so that's one of the things that we've learned, that you've got to be able to provide services for everybody, Medicare, Medicaid, private insurance, in a community, and also open it up to multiple specialties to be able to sustain the program in the long run.
Oh, that's so interesting. And so I guess that makes me wonder, how do you figure out which disciplines you want to go after? You know, that and across all those payer groups too, you know, knowing that there's going to be a demand.
One of the things when doing our community assessments, when we go in and talk to the clinics, or whether it's an FQHC, a rural health clinic, a critical access hospital, whoever happens to be in those communities, finding out what type of patients that they have that they're having to refer out to for. And so based on what their needs are is kind of how we're really focusing on what we're providing to them. That goes along with, as we build out new sites and we do these assessments, we look at what their needs are to determine what type of technology it is that they need to have as well. If all they're needing is mental health services, you don't need to put a $30,000, $40,000 card in there with stethoscopes and otoscopes and general exam cameras. All you need is a monitor and a camera. And so that's really, really important to be able to do that and go out and do those assessments to see what it is that they need, what services that they need. And that's kind of how we base what services we provide, is based on what the communities need.
Okay. And you have to aggregate that up across all the different communities, right? So that you see that you actually have enough volume across all of them put together to make it worthwhile.
Exactly. And, you know, with having multiple campuses, we've got 4 medical school campuses throughout West Texas, one in El Paso, one in Midland, Odessa, the one here in Lubbock, and the one in Amarillo. And we've actually equipped all of our campuses with telemedicine technology to a certain extent. The majority of the specialties that we have are here in Lubbock, but we do have some areas that they don't have certain specialties in their communities, and so we can offer services to those communities through the technology. Just as an example, like I said, in El Paso, in pediatrics, we've got equipment, and we're doing our pediatric dermatology patients. So it doesn't matter whether they're a Texas Tech patient or they're a community patient, a doctor from another outside the facility. Our pediatric department has allowed them to come in and be seen through the technology for dermatology clinics to try to save the patients and the system some money. So, you know, we're really trying to figure out how we can even go outside of what our normal patient level is to provide services and open it up to anybody that needs it.
Right, so you can continue to get that increase in utilization across the board, right? Okay. Any other big decisions that you want to touch on?
You know, obviously trying to figure out how to expand out your program, and how fast you want to expand out the program. It is a big decision, because you want to make sure that you can provide the services that the communities that you expand out to are wanting. And so, those decisions are always tough, because I'll go out and assess a community and just really try to figure out how to get them involved in telemedicine. And after doing assessments, the long-term sustainability, I just don't see it. And so I have to let the communities know that, as it stands right now, the way that you want this focused, it's not going to be sustainable. And so those are tough decisions too, because, you really want to be able to help everybody, but there comes a point where, the community is just too small to be able to have enough patient base to make it sustainable in the long run. And that's a tough decision to make in telecommunity.
Yeah, I can see that, right? And I can imagine they're pretty disappointed, because they want to bring that care over to their
Exactly.
community, right?
But you have to make them realize that, unless the clinic itself can get support from, the county or the city or something like that, that clinic is just not going to be able to maintain, the connectivity charges and the lease agreement charges for equipment based on the patient load that they have. And so, it's, you put it back, and once again, this has got to be a community effort because of situations like that.
Mm-hmm. And since you know about what these charges are typically, do you have a ballpark that's generally applicable, that you can tell a community that it's going to cost you roughly X hundreds of thousands or dollars
Yes.
a month?
Excuse me. Most of the communities that we go into, we can run DSL lines into the clinics. And so in West Texas, a DSL line that's capable of running equipment will run you anywhere from $100 to $200 a month, just depending on where they're located at. So, that's that ongoing cost, whether you see a patient or not, you're going to be responsible for that. And then for the equipment, if they buy equipment outright, it can cost you anywhere from $10,000 to $30,000, depending on what you want to be able to provide services for.
You're talking about like a telemedicine cart,
Yes,
or the video conferencing unit, right? Primarily.
Right. And we do have some equipment that we have from those 19 sites. We got all the equipment back from the sites that didn't want to continue on, and so we've been able to lease equipment out to some communities to help them, so that they're not having to actually fork out $30,000 up front to pay for the technology. And so we've been blessed in that sense, and that's really helped us be able to expand out our program to more communities, is because we had equipment in-house that we could lease out to them.
Yeah, that's great. So how many communities do you have that you're serving overall now, plus the correctional centers?
Right now, we've got 15 correctional units, and I've got 12 community-based sites, in addition to our 4 regional campuses that we do various programs with.
A big network.
Yeah, not big enough though. I mean,
Yeah.
there's still areas that we need to figure out how to better access, and so that's one of the things that I work on a weekly basis, is trying to identify communities where we're getting a lot of patient base in from, and going and talking to them just to see if what the possibility of setting telemedicine up for their patients is.
And that challenge, is that more of a, we need to get visibility, or we need to, or are they coming to you saying, hey, we love this, but, what does it really take?
Both. Some of it is a patient has come in, and we have signage. I've got a monitor outside on the wall of our office that has telemedicine stuff going on all the time. And so we get calls from patients and say, okay, I saw your telemedicine monitor. Tell me how I can be seen over telemedicine so I don't have to drive 2 hours in to see my doctor. And so some of it's driven that way. Some of it is a hospital administrator has been at another hospital that has telemedicine, and they said, hey, we want to learn about that. Is that something that we can do? So, it's kind of a combination. Some of it is I work with the different departments to see, where are their patient loads coming from? Is there a certain area that they're getting a lot of patients in from? And if that's the case, maybe, I go and try to start talking to the communities and say, hey, a lot of your patients are coming into Lubbock. Let's talk about telemedicine and see if this is an opportunity to keep your patients here as opposed to having them travel on the road to be seen.
Mm-hmm. Okay. So now, let's see. Knowing what you know now, is there anything you would have done differently in your experience?
I don't know that there is, because it's the challenges that have taught us what needs to be changed in the long run. So if we hadn't had those challenges, I don't know that we would be where we're at today. So, changing something, I don't know. I mean, I would change the state legislator and make reimbursement a lot sooner, but, other than things like that, I think that, the learning curve that we've learned from, that, the mistakes that we've made has really helped us know what we need to do in the future. And without making those mistakes, we wouldn't know what we need to do to go forward.
Right. Very cool. Good. Yeah, and it's always a learning experience. Sometimes there's just no way to make up for the mistakes, right?
Exactly.
I mean, if you learn from them, that's the best thing you can do.
Exactly.
And yeah. All right. So what advice would you have for someone who's just starting out with their telemedicine program, whether it's an academic medical center or not? Any do's and don'ts? Yeah.
I think one of the things, learn as much as you can about the reimbursement in your state. Learn about what the medical board rules are in your state for doing telemedicine, and then talk to as many people as you can that are already providing the type of services that you want, whether it's mental health services or neurological services, those kind of things, to try to learn as much as you can and then build your plan from what you've learned from the others. There's a lot of resources out there. American Telemedicine Association is a great resource. There's a lot of telehealth resource centers throughout the U.S. that have good insight, and they're good people to be able to talk to gain that knowledge base to learn what you need to do. The other thing is, if you're looking at technology and the equipment, talk to as many vendors as you can. Have them come out and do demos of their equipment and look at what all your options are, because there's a lot more vendors doing telemedicine now than there were even 10 years ago when we were trying to build our programs. And so there's a lot more opportunity at a lot less cost now than there were when we first started. The biggest expense in telemedicine equipment is in the peripheral devices, and it's because up until recently there just hasn't been very many vendors that were providing those type of equipment. And so now, because there's more and more vendors, it's becoming more competitive, and so there's a whole lot more options.
And you're talking about like the scopes and maybe even an ultrasound that you can attach and
exactly. And we've been testing out iPods and or iPads and BlackBerry tablets and things like that to see what we can accomplish on a smaller scale. We are equipping a lot of our medical students with software technology and video cameras so that they can link back in through a laptop to do classroom work, or as they're doing their rural rotations, they can use that technology to link back to talk to a professor, or, we're figuring out, can we use it to present patients if we have devices that we can attach to the laptop. So we're really, we're constantly looking at what new technology is out there that we can use that will make it more affordable in the long run.
That's great. And so you're able to think about how you could actually change one technology out for another later on as well, because then your physicians primarily would end up having to use potentially different technologies, one for one location and another for another one. Is that true
Yeah,
or no?
basically, with the tablets, if you have a physician that's getting ready to discharge a patient, um, with all of the um, continuum of care issues that we're trying to come up with, the readmittance avoidance, our concept that we're trying to develop and work on right now is equip that physician with a tablet, have him link back to the primary care provider of that patient so that they can discuss, okay, treatment plans once they get back to their community, what they need to do to keep them from being readmitted to the hospital. And so that can be done in the patient's room before they get discharged, linking back to their primary care provider so that they have that continuum of care coordinated so that that patient can be taken care of the best way possible. And so utilizing, the iPad or the BlackBerry tablet or things like that, it is a great opportunity to be able to do those kind of services.
That's cool. And so now, one last thing based on, you're a telemedicine director and you see all the great successes, you see some of the challenges of what you get to, what you deal with on a day-to-day basis. What would you say, well, two things. One, what excites you about the technologies and capabilities you see coming out, right? And I know you're working on the iPads and iPhones and everything. And two, what would you say to a telemedicine vendor saying, hey, you know what? I'd love it if you would come up with something like this.
Well, first, what excites me is that we can do so much with a lot less technology. Excuse me. We can use the iPad to be able to link and talk back and forth. We can use the technology to link to other countries. We're not doing that right now, but we've got several countries right now that are talking to us to try to figure out if we can provide services to them. And I think that, the opportunity there is just huge. And it's not going to cost a lot because the technology has come down in price so much that we'll be able to do a lot more for a lot less. And so that's what excites me about, the technology. As far as something to recommend to vendors, they've got to look at, as we shrink the technology pieces, using laptops and using tablets and things like that, they've got to come up with devices that we can attach to the laptops, otoscopes, stethoscopes, general exam cameras, that are good quality that we can run through a laptop to make it more mobile. And so that would be my recommendation to them.
That's cool. Okay, very good. And okay, the last question for you. What's next for your program? And where do you see things going?
Well, we have applied to be a telehealth resource center. We applied for the grant. I'm still waiting on that. Right now, Texas and Louisiana doesn't have a resource center attached to us, and so we applied for that. I'm keeping my fingers crossed that that's going to occur. We get a lot of requests, not only statewide, but from other communities across the U.S. about trying to do telemedicine. We've been doing this since 1990, so in a lot of ways people look to us as, okay, you've been doing it for a long time, help us, let's learn from you. And so we're trying to take that and be able to expand that out through a resource center. So that's one of the things that we're hoping to get good news later this month about